Good evening, everyone. It's 5 o'clock. I'm Dr. Patrick O'Shaughnessy, Catholic Health's Executive Vice President and Chief Clinical Officer. Welcome to our special panel about the COVID-19 vaccine. We know many of you have questions regarding vaccine, and so we've gathered a team of infectious disease experts to provide answers to your questions. Because we do have hundreds of people on the line, all attendees are muted. So if you'd like to ask a question, please use the chat feature in the box on the right. We have a number of questions already submitted, and we'll try to get to as many as possible. If there are questions we can't get to, you may continue to submit questions after the webinar via info@chsli.org. Now, it's my pleasure to introduce my fellow colleagues, Good Samaritan Hospital infectious disease specialist and head of the hospital's COVID-19 task force, Dr. Uzma Syed. I'd also like to introduce St. Francis Hospital Director of Infectious Disease, Dr. Alan Bulbin. Thank you both for joining tonight. And let me start by also thanking all of our employees for the incredible work that you do in managing our patients and residents each day. We would have not gotten through all of the COVID challenges without the incredible work that you all provide every day. So on behalf of everyone at Catholic Health, I can't thank you all enough. And I'm glad you're all here. We're going to have a great discussion tonight. Let me start just with our two panelists. I want to give them the opportunity to share a little bit about themselves. Because for those of you who watch maybe the Dr. O Catholic Health Show, you know one of my key things I always speak to is I want to navigate you to sources of truth, because there's so much, especially around COVID and COVID vaccine, we really want to make sure that you know where to go to find answers. So we thought, what better source of truth than to have two of our infectious disease leaders and experts. I've worked with both Alan and Uzma throughout the whole COVID response. They're amazing. And we have them here for you tonight. So let me let them introduce themselves a little bit, and then we're going to jump right into the questions. Okay? So Dr. Bulbin, why don't we start with you? Maybe give a little bit of background about yourself.
Thanks, Patrick. Well, it's a pleasure to be here. Vaccines, I think, are something we really are focused on right now, and rightfully so. I think, as I stated before, I believe we're now seeing the light at the end of the tunnel, but we're still in the tunnel. But for me, it's been a journey since 1993 when I first came to St. Francis, and then 2007, I became the director of the Department of Infectious Disease and served on the Infection Control Committee, and later started the Antimicrobial Stewardship Program. And my career kind of spans two pandemics that have now come together. One of my influences originally was HIV, and now, 30 years later, COVID. And so it's really become kind of an interesting parallel in how these two things have brought me to this point. So I really enjoy the role that I've been given, and it's a challenge for all of us. And as a leader in my field, I believe all of us as healthcare providers should be leaders when it comes to discussing vaccines and what they mean to us, and especially to set the stage for the general public, who, if we have all these questions and these challenges and hurdles to overcome getting the vaccine ready and rolling, just imagine the general public. So I'm very happy to be here to discuss all of these issues.
Great. It's great to have you. Thank you, Alan.
Thank you.
Dr. Syed, how about you?
Absolutely. Thank you so much, Patrick, for the invitation. Thank you so much for hosting this. I think this is a much needed forum. I've sort of been, along with Alan, we've been sort of doing this ad hoc, sort of improvised on the fly with, any staff and any community members. Education has been ongoing since even before the vaccine rollout. And this has been really something that I've been very passionate about, with the ongoing global pandemic, just educating the public, because, as we know, a year into this now, the amount of misinformation that has been shared, it's a constant work to really undo all of that, and to really get ahead of it and to share, credible, accurate, evidence-based, science-driven information with people so that, they can really have the right information and make informed decisions. So, I'm very passionate about global health, pandemics. This has been really an exciting time for us in infectious diseases. It's a dream and a nightmare all kind of tied up in one. Unfortunately, we're seeing, so much mortality and so much disability and despair, and we're really hoping for a better and brighter future just around the corner, as Dr. Bulbin mentioned, but it really takes a collective effort for all of us. So I've been very active at Good Samaritan, helping them, leading the task force. I remember this time last year, I was ringing the alarm at the hospital and just really worried about what was on the horizon, first reading the reports out of Wuhan in December, just not being able to sleep at night. I have some of those anxieties again with some of these variants, but again, we have learned so much about this virus, and there's so much that we have gained, especially on the vaccine front, that has just been, a miracle for science. So I'm very happy to be here and to continue to share this information. So thank you.
Well, it's great to have you both, and this is what makes CHS great, right? I mean, we have hundreds of incredible providers like you, and it's been a pleasure and privilege to work alongside you during the COVID-19 pandemic and CHS's response to that. So let me just set the stage a little bit about why we're here, and it's understandable, right? I mean, when you think about it, we had an initiative named Project Warp Speed, right? And so there was a big push to try to get something out in terms of vaccines, and even the name of that could actually, make people a little nervous. And, we have people in the health field on the line now. We have over 300 folks joining us tonight. And these are folks that are educated, and the reason why we're here is we only have about 50% of our employees in aggregate throughout the CHS system who have been vaccinated. Now, that doesn't, include those that have declined or are waiting to get vaccinated. So again, our overall percentage rate, likely when you factor that out, is higher. But we really are here tonight to kind of answer questions, get people comfortable, base it off of science, dispel the myths, and so that folks realize, hey, this is a good thing. And we've seen so much death and so much suffering. The fact that we do have safe and efficacious vaccines out there and available is really a godsend. So we want to make sure we answer questions and concerns as best as possible. Part of what I always try to share again is source of truth. At the onset of when we were getting together, Alan and Uzma, you both shared a New England Journal article paper. We will, for folks who are watching, we will link that. We will put that in afterwards. It has a great Q&A in it, and it's a great thing to go back and refer to. And then, also, I always recommend a source of truth. The CDC website has a great section. I'm going to hold this up for you. If you can see it, it actually gets into all frequently asked questions about COVID vaccination. They're a great source of truth. And I realize with the advent of mobile technology and internet, you really, really have to be careful about what's true and factual and what's not. So we're really fortunate we have our experts with us tonight. So let's dive right into the questions. So my first question, Dr. Bulbin, and Alan, the question is, many folks question how fast the vaccine was rolled out. I mentioned Operation Warp Speed, and therefore its safety. What can you tell us about the development and the phases of completion for the COVID-19 vaccine?
Right. Well, the technology, the messenger RNA technology that is now being used for the two available vaccines, the Pfizer vaccine and the Moderna vaccine that are out there right now, utilize messenger RNA technology to promote an immune response. Now, these mRNA platforms, company research, they've been around actually for quite a while, well over 10 years. And some early vaccine platforms were, rolled out and looked at, and just trying to find the niche. And guess what? With the onset of COVID, the niche was right there. It was well-intentioned and now an application for this technology that's kind of been on the shelf for many years was now put into place. So it's not like it was just invented overnight and they just, started it with COVID. No, it was now found a niche, and with backing of all these resources, be it financial, be it governmental, be it pharmaceutical, private, now there was a full force behind, for the first time, using messenger RNA technology for widespread application. And the key was this lipid solute, the way to package the messenger RNA so that it can be used in a widespread fashion. So it's not new in that sense, but the fact that it's a first go with a large population, yeah, I mean, any vaccine, when it is first rolled out, there may be unforeseen, occurrences. Everybody's really focused on the side effect profile because it is a first use, it is so new. But the side effects are predictable and I think well established. And the bottom line is, it's the efficacy, as you mentioned, Patrick, that the data doesn't lie. When you come out with a vaccine that is 95% effective in preventing an illness, you're really talking about an amazing response. It really, ranks with any of the best vaccines that have ever been produced. So it's been on the shelf, now in full force with really great data. So I think people are just more, there's a little fear and apprehension about the side effect profile, which we can, I'm sure, delve into, and I'm sure there'll be a lot of questions about that. But just realize this is not brand new. This is, and the fact is, the science was there for us to give us something to rely on. And this messenger RNA, just the way it works, is really incredible. I've explained it before. It's just utilizing our own cellular machinery to create the protein that is the same exact protein on the surface of the virus. So it's not a live virus. It's not even a dead virus. It's not even a piece of a virus. It's using our own cellular machinery to create the protein and then induce a response, an effective immune response as a result.
Right, and I think that's an important point. You touched on this. And I'm gonna bump this one to Dr. Syed, because that's part of what I think gives people a little bit of apprehension, right? Because, and I was a biochemistry undergrad. I don't know if you folks were, but I remember all the pathways, and I know the function of messenger RNA, to your point, in producing proteins and translocating proteins. So, Dr. Syed, can a messenger RNA virus integrate into our cellular DNA and change our DNA structure?
I think that's such an excellent question. I'm going to start off by answering that and then go back, piggyback a little bit on what Alan was saying before about the phases. But that's a question we get almost, I don't know how many times a day, that, this vaccine is going to alter my DNA and I'm going to turn into a mutant or something. There's this myth that's floating around there, when in fact messenger RNA doesn't even enter the nucleus of a cell. So, that theory in itself kind of immediately, debunks that whole thought process that this is going to alter your DNA. So that's one thing that people need to, really understand, is that this, vaccine, the messenger RNA that's in there, is really, quite unstable actually, which is why, this lipid outer layer is needed, so that it can actually, and these cold, sub-zero temperatures are needed to really make sure that it's there until it's, given into the arm, and it stays at the local site. And once it instructs your body to make, the protein, it essentially just disintegrates. Your body just gets rid of it on its own. It's not something that lingers around in your system for weeks and months and years. It's used, it does its job. It tells your body to make the protein, and then your body just gets rid of it. So that's something that's really important. It does not enter the nucleus. It does not alter your DNA. So these are some basic things, misconceptions that are out there. Going back a little bit on the phases and the clinical trials, this is also another concern that a lot of people have. Just as you mentioned before, by starting off with the name Operation Warp Speed, was really a poor choice of wording, because, you know, it really kind of leads to, you know, this mistrust that we're rushing something, you know, and especially there is an urgency given the global scale of the pandemic that we're in, but people don't realize how much of a concerted global effort there has been for vaccine development, and also that we've had so much research and data from our previous coronavirus pandemics, such as SARS and MERS. You know, those pandemics never, you know, held on to the scale that COVID-19 has, fortunately. So the data and the research and the vaccine development that we had with those previous coronaviruses never came to full, you know, phase 3 clinical trials and finishing them, because the virus has essentially died out. So we didn't have to worry about it. It didn't, you know, propagate to this level. Not only that, we've had, you know, mRNA vaccines for other viruses such as Zika and CMV, and they've been used for cancer therapeutics. So, you know, it's been in development and use since the 1990s. So it's not something that was essentially invented overnight. So that's another thing that people need to appreciate, is that this technology has been looked at for a long, long time. The phases of the clinical trials, you know, there was no time where there was safety or efficacy, especially safety, was jeopardized in any of these clinical trials. In fact, there was so much focus on that 9 of the major pharmaceuticals signed an agreement in September for full, you know, transparency with these vaccine trials to gain public trust. And they also said that they would hold their vaccine candidates to the highest standard possible. So much so that the FDA also, when these vaccine candidates were ready to submit their data, 1 month out, the FDA actually said, actually give me data from 2 months from, you know, the phase 3 of the clinical trial. So they went a step further. So the reason why we're able to be at this stage, you know, in the pandemic, have these vaccine candidates is, one, that we already had research on coronaviruses before. 2, the science, the advances in science, where in record time, when from the first case that was reported in Wuhan to the actual sequencing of the virus was about 66 days. And then the scientists just went to work, where the entire global community came together on vaccine development. And we found the things that were really inadequate in our current approaches for research. You know, there was a lot of redundancy. There was a lot of, you know, initial visitation, come back, and then we'll do your vitals, come back, and then we'll do your blood work. You know, it was just ineffective. So a lot of those things were sort of consolidated so that we can meet this timeline. But the safety of these vaccine candidates was never jeopardized, because everything was still held to that transparent level where people would be able to see what's happening in each phase of the trials, the way that we traditionally follow them.
Right, I thank you for that, you know, response, because I think it's important that we lay the groundwork here, right? No phases were skipped; they were all completed. You're not going to get your DNA altered by taking one of these vaccines. Efficacy 95% and up in terms of giving you the effective immune response to protect you from COVID infection. So,
Patrick, just to get back to your question, you mentioned about younger people and some of the you know, hurdles that they might think about. As you said, well, I'm young, I'm not like an older person, I'm not immunocompromised. COVID, perhaps it's a different perspective, but you have to realize your risk of getting COVID, even as of today, is much higher than having a side effect from one of these vaccines. So if you look at in those terms, that do you really want COVID, or do you have some other way to prevent it? You know, we will still have to mitigate, continue to wear masks, social distance, hand washing, and those are still super, super important. But in the meantime, we have this tool of the vaccine, and as Adriane said, it's been well vetted, and you know, the safety we could break down. But even as a younger person, I think you know, if you don't choose to receive the vaccine, that, you know, that's a personal decision, but you're also choosing to potentially still be at risk for COVID. And if you're wondering about any long-term effects that haven't even really been defined from the vaccine, there really haven't been many. You know, I know the vaccine has really been looked at just since this past summer, but over that period of time, there really haven't been any signals that suggest long-term effects, like some of the more rare things like Guillain-Barré syndrome or transverse myelitis, or these really serious vaccine-associated complications. They're just not being seen. But we do know if you get COVID, even as a young person, you could be at risk for, long hauler symptoms, fatigue, headaches, just to name a few. Or we mentioned cardiomyopathy, the rare chance that, an otherwise young, healthy person develops, heart failure out of nowhere, and they could have even had asymptomatic disease as the trigger. So you have to always put it in perspective. Do you really want to put yourself at risk for COVID, even right now when the prevalence of COVID is still pretty high?
It is.
And it could be high depending on your, you might hear a number of 7%, but if you're in a large group, if you're in a super spreader environment, then that number may triple. So even as a young person, you have to view it as a perspective. Do you want anything to do with COVID? Take every opportunity to avoid COVID in a safe, predictable way. Or do you want to take your chances and get COVID and then potentially, although rare, have some long-term effect from that infection? So for me, it was so simple to, I took the vaccine the second one it was available, the first day,
right,
and got my second shot. And I just, again, as I mentioned, I just feel like it's this light at the end of the tunnel. It's just such a good feeling that I've now been vaccinated, and I'm still going to do everything in my power to avoid it. But I understand the numbers. And then just to end this segment, again, the chance of a side effect is so low compared to your chance of getting COVID here and now on this date and this time.
Alan, I completely agree with you. Let's pivot. I want to ask Dr. Syed a question, because we talked about younger population, and that's I'm trying to aggregate what the big concerns are with our incredible team members at CHS, and that's one of them. So I think great job addressing it between Adriane and Alan. Thank you both. Let's talk about pregnancy or women of childbearing age. Let's dispel some of the myths. Let's speak to some of the data and the facts. Uzma, can you speak to this population, and what would you advise women of childbearing age regarding COVID vaccine? And then maybe you can talk a little bit about the background on the research and pregnancy as well.
Absolutely. This is a really important topic that needs to be addressed. This is, again, one of the primary questions that I get from many, not just healthcare workers, but community members, females, the misinformation that's been spread about infertility. And then there's, the concern about pregnancy and vaccinations. So first and foremost, we know for a fact, the effects of COVID, we've seen it firsthand. We're in the thick of this pandemic now. And unfortunately, we have seen pregnant women end up being hospitalized with COVID-19. And not only do they get hospitalized, but they're at increased risk for ICU care and needing ICU care. That in itself is a complication that we're not happy about, because that puts the mothers at risk, puts the baby at risk. There's increased risk of preterm labor with COVID-19. So pregnancy in itself, puts you at higher risk of complications from COVID-19. And so, knowing that, there's a serious discussion that, pregnant women should be having with their OBGYNs to discuss risks and benefits of getting vaccinated. Now, although pregnant women were not included in the clinical trials, this is not unusual. Most clinical trials do not include, pregnant women initially, and most of the time, the data that we have, even historically, is usually from women just inadvertently getting pregnant and then having the data from it to show that, oh, it is safe. And many of our vaccines have been established this way. And looking at the two vaccine candidates that we have, actually, even though, the women that were in these trials were advised to not get pregnant, there were still about 30 or so women that did get pregnant in both of these vaccine trials, in both the Moderna and Pfizer. So we have a little bit of data, and now, across the country, essentially, all of the large organizations, the American College of Obstetrics and Gynecology, American Academy of Pediatrics, Maternal Fetal Medicine, all the associations, Infectious Disease Society of America, everyone has really come out in support of pregnant women getting vaccinated, because the risk of COVID-19 far outweighs, the risk of any potential side effects from the vaccines. Now, the most common side effects, because it is a reactogenic vaccine that we see in any person, is, you know, up to 48 hours after vaccination, you can have not only arm soreness, but you can have some fevers, chills, body aches. This is not unusual, and we always advise patients to take something, you know, whether it's Tylenol or ibuprofen. In pregnancy, the caveat there is that fever in itself can be dangerous, you know, for the baby. So we always advise that pregnant women are keeping track of their fevers and their temperatures and making sure that they're using acetaminophen or Tylenol to really keep that temperature down. But these are conversations that are going on across the country, and most physicians are really encouraging their patients who are pregnant to get vaccinated, because the risk of COVID-19 really outweighs, the benefit. It really outweighs the risk, you know, of vaccination.
And then also, you know, so that's the pregnancy piece. Women of childbearing age, you know, there's been some things about issues around fertility and placental issues. No data around any of that.
No,
I mean, what about for women just of childbearing age?
Right. So just to prove that point, you know, I have been asked this question so many times about the fertility. I don't know where it arose from, but, you know, the misinformation just spreads like wildfire. But first, we already mentioned that the messenger RNA doesn't enter the nucleus. Second, we already know it's only asking your body to make a part of the protein, as Dr. Bulbin mentioned before. There's no part of the virus, dead or alive, in the vaccine itself. So that's off the table. People that have had COVID, you know, infection from COVID-19 have been able to get pregnant. So there's no reason to think, if you're asking your body to make spike protein, that there would be any issue with that. And then another whole fold of that is that people who were in the trials inadvertently still got pregnant while getting vaccinated. So, you know, the infertility thing is really, you know, that just puts it to bed that there's no basis for any of these infertility concerns. So, you know, there really should not be any concern with that moving forward.
Excellent, thank you. I think that really lays it out for like the two big groups of our team members and the big broader concerns. Let's dive into some more specific questions. So we have a large population of people who are getting vaccinated, which is good. We want to see that number come up. We want to protect everyone. The question becomes, and this is, I'm going to do this on a two-part because there are plenty of people out there, unfortunately, that have had COVID, and now they have perhaps some innate immunity. Again, there's a lot of debate in the literature about how long this lasts. Again, guidance from all of the agencies say still get vaccinated even if you had COVID. But let's talk about how long would immunity last specifically with the vaccine. Do we know yet? Do we know, will we need a booster? Will this be an annual thing like a flu shot? Maybe more time will tell. Alan, why don't you take that one?
Right. Well, as I said, the vaccine's only been rolled out since this past summer, and a lot of the questions that you mentioned, we don't have all the answers. What we do know is that from natural infection, you know, depending on how sick you were, how symptomatic, how high your viral load might have been, it could affect the level of immunity that you develop from natural infection. And it's thought that that immunity is probably going to help you for a minimum of 90 days. And if you were an asymptomatic patient versus somebody who was severely ill and recovered, well, maybe that asymptomatic patient, their antibodies have been shown to wane much more quickly. Whether that means you lose all immunity, we don't know the answer, but there's a lot of signaling there that might suggest, you know, the immunity is not even perfect from natural infection. And the immunity you develop from natural infection in March might be a little less than the immunity you need to supersede one of these variants that is now showing up and is certainly here. I mean, these variants that have been described in the UK and South Africa and Brazil, if you think they're there, they're definitely here as well. So, you know, this is what viruses do, they mutate. So to keep ahead of that, we need to get our population immune any way possible, whether that is through natural infection, which we would like to avoid, but certainly through rolling out a massive vaccine program to stay ahead of these variants. So the immunity that you develop from the vaccine is now well established. These studies show 95% effective in terms of preventing disease, and certainly no one, even if you do develop disease after a vaccine, nobody had severe disease. So it's just an amazing number, 95%. So
Right.
if you've had COVID and you want to bolster, you want to boost that immunity to ensure that maybe you could even extend it lifelong. I'll throw that out there, that there is a possibility that this could be lifelong immunity. We don't know that. But to shore up your immunity from natural infection as a booster effect, everybody recommends you should receive a vaccine, even if you've previously been infected. And that gets to the reason for the second shot. You know, that primer from the first shot is there, but the second shot boosts that response tremendously. And that's really what gives you perhaps that long-term, even lifelong immunity. But that's going to be monitored, and we'll see how it all plays out. Another advantage of the messenger RNA technology is that if there is a variant that has been shown to escape your immunity, which the good news right now, we're being told that these variants, as I mentioned, you know, some early reports now show that, hey, the current messenger RNA vaccines are effective even against those variants. So it's even more important to roll these vaccines out before another variant or a variant after that. So this immunity is really key to, you know, getting us to the summer or to the fall when this just all dies out.
Well, that's what we're all hoping for.
Yeah,
and thanks for addressing the issue, because this also comes up even amongst clinicians, right? And we have some online with us tonight that say, hey, wait a minute, I'm just not getting the fact if you're telling me the vaccine gives me better immunity than me actually being sick. And the answer is yes, it actually does. And I think there's good evidence in the literature to show that, and especially around the mRNA and with the second booster and whatnot. Let's get into variants, because that's come up, and that comes up even from our governor as recently as today. I'd like to have Uzma, you address this, because like you, I'm still losing sleep over a lot of this with COVID. And you know, we had this conversation back in February. I'm 100% agreement. We saw how this whole thing evolve. Viruses have variants, right? And maybe dive into a little bit. And I'm hoping that we can calm the masses with this, because, you know, people out there, many folks, I'm trying to remember the movie, the movie with about the virus that mutates into this horrible thing and wipes everything out. You know, yes, thank you. So but there's folks that they hear this by the news and the lay media, and they're afraid and they're concerned. So Uzma, can you address the issue around variants? This is what happens with viruses and the points around this?
Absolutely. Yeah, there are things that, you know, we have to take, you know, with a grain of salt, and there's other things that we do have to be attuned to so that we're prepared. So mutations for viruses are not unusual. Coronavirus actually mutates at a less pace than other traditional viruses. For example, half the rate of influenza and a quarter the rate of HIV. So it's not unusual to have these single mutations in the coronavirus strains, and most recently, before all of these variants emerged, what we heard about last was the D614G mutation, and that became the dominant strain, right? And then after that, we didn't really hear much about it. We knew that it was more transmissible. We knew that it was not more severe, and it was fine. That was the dominant strain. Now that we started looking, and essentially in the UK is where they first discovered the B117 variant. In South Africa, they discovered their variant. In Brazil, there's a P1. You know, and now we're ramping up our genomic surveillance in the US, because we were really not doing, you know, we're doing essentially a fraction of the amount of the rest of the world. If you look at just December alone, we've sequenced about 37 genomes, where the UK has done, I think, 3,700. So, you know, that is going to be ramped up, and the idea is to really be ahead of it. So the thing with the mutations with these coronaviruses is usually it's not that significant. Usually the case is that, you know, it's a slow evolution, and it would take many, many years for the virus to have mutated significantly to really escape, you know, vaccinations. The thing that's different with these variants that have just very recently emerged is the amount of mutations that happen simultaneously. So that's what's unique about this. And the reason why we think that this is happening is, in fact, just the global scale of the pandemic, how much virus there really is out there, and how there are certain people who the theory is that they could be, their immune system could be suppressed, where this virus is sort of lingering and it has, this opportunity to keep mutating to a better version that can sustain itself, right? So these are the concerns when we keep having these mutations happening simultaneously in these variants. As Alan mentioned, Pfizer actually has already tested, and Moderna is testing their vaccine currently for the B.1.1.7 variant. Pfizer has already released its data showing that the vaccine is effective for the B.1.1.7 variant. So that's good news, because we know that that variant is in Long Island, in New York, and we know that it's, widespread throughout the country, which again is not surprising to any of us in infectious diseases, right? We knew if you look for it, you will find it. The concerning variants are really, the South African one and the Brazilian one. And right now, they're restricted to less countries. P1 is really only in 3 countries. And so, we're really keeping an eye on that. And recently there was another variant that was just discovered in California as well. So everyone is doing all the work right now diligently to see what are the implications of these variants. But the ultimate thing that is most important is that this is essentially a race of us against the coronavirus, right? So how do we get ahead of it? We have to vaccinate like there's no tomorrow. We have to get ahead of it. The sooner we vaccinate, the sooner we stop this transmission, the less the virus has a chance to mutate. And that's how we get ahead of it, because we don't want to run into a situation where we do have variants that are going to escape, these vaccines. And then, as Alan mentioned, these mRNA vaccines are great that they can be tweaked. Right now, we're trying to just get through our first cycle of vaccinations and have that be adequate to reach herd immunity quickly. So then to talk about tweaking those and then revaccinating, that's another hurdle. So how can we be effective? Let's just stop the transmission of the virus as much as we possibly can, vaccinate people as much as we can, so that we can really get ahead of this and get back to some sense of normalcy.
Thank you. And so clearly answered that issue. The other piece to this is, on the variants, nothing shown relative to increased morbidity, mortality relative to the variants, right? Transmissibility was always high with COVID, which is how we got in this situation, right? On the R0, which is a measure of how many people can be infected by the virus. It's got a relatively high number.
That's a very good point. Yeah, that I didn't get to mention is that it has not proven to be lead to more severe illness. But when you talk about transmissibility, we're talking about these variants being, at least 50% more transmissible, because it can bind to the receptor much easier. So what that means is that it increases R0 by at least 0.8. So we're going from 2.5 to almost, higher than 3. So, this is something that can have significant impact. And we're seeing that in the UK. You see that steep incline. We're seeing it in different parts of the country. So again, really want to just get ahead of it. Even though it may not be causing more severe disease, COVID itself is killing 4,000 people a day. So, we have to get ahead of this.
I agree. Thank you for explaining that. Let's move on to the next question. This one comes up all the time as well. So Alan, I'm going to give this one to you. Can you still transmit? We know you're not going to get sick if you get vaccinated, but if you do get re-exposed, could you transmit COVID in the setting of after being vaccinated?
Yeah, that's still somewhat of a nebulous subject, in that we don't know. We definitely don't know. But the point, but you could take some features of what we do know and apply it to this issue. So when in the studies, the Moderna study, in fact, when people registered, they had a nasal swab done at the beginning, and then when they came for their second shot 4 weeks later, they would have another nasal swab, whether you received the placebo or the actual vaccine. They were screening all the participants. And they did see some people with asymptomatic disease, swabs that were positive in the placebo group, as well as a small number in the group that had received one vaccine at that point. This was 4 weeks later. But the number, it was much, much less, very small in the vaccine group compared to the placebo group, probably on an order of 3/4 the number. So already that tells you it could happen even after 1 dose, but at a much lower rate than the placebo group. After 2 doses with high immunity, it's still probably possible, but it becomes less and less even at that point. And I would venture to say, even if you are an asymptomatic, colonizer or carrier after your second vaccine, the viral burden is going to be extremely low, and you're going to be less infectious. But hopefully, you'll be along with 4 out of 5 other people who have been vaccinated and are immune, so there's nobody to spread it to. That's the other point. So it's theoretically possible, and it may happen even for a short period of time. But I think it's going to be at such a low level, it's just not going to be an issue. But we have to look past that, as I said, to get everyone vaccinated so it becomes a complete non-issue. So if you're worried now that you're getting vaccinated as a healthcare provider and going into the front line and you're immune, but you're potentially going to become an asymptomatic carrier and bring it to your house or your family, theoretically it might be possible, but I think it's at such a low level, and you would probably shed that virus pretty quickly, that it's really not a credible risk to your family on an ongoing basis. Agreed. At some point, the immunity is going to be so good that this probably doesn't even happen.
Agreed. Alan, that was excellent. Thank you. We're getting live questions bouncing in now, so I want to get to a couple of these as well. This one, Uzma, I'm going to give to you. And this one comes up a lot about testing, right? So I'm gonna frame it and then try to summarize what this person wrote in. They've had the virus at the end of November. They were tested for antibodies. They had positive antibodies showing that they had past infection. They did exactly what you did. This is a healthcare professional, got vaccinated, and then was tested again, and they're getting positive and negative flipping results. So Uzma, maybe what you could do is let's stick with first PCR testing for COVID infection, because there are people that, this is an issue for us in the hospitals as well. They continue to maintain a positive PCR, but they're no longer active infectious. So maybe unpack PCR testing first, and then if you could give a little summary on antibody levels, again, for what it's worth, and the flipping positive and negative on that. And is there any advice you could give? Because we have, our healthcare professionals on the line here, and these are the real kind of world questions we're getting asked. So Uzma, could you try to address those?
Absolutely. So we know, especially being in healthcare, we have seen firsthand how sensitive these PCR tests are. And we know that, we initially last year, when, a year ago when we first started this, there's all this guidance from CDC to have repeat PCR testing to clear people of infection. And very quickly, we learned how people can have sustained positive PCR tests for weeks and weeks and weeks and even months. And that does not really indicate active infection. And we know that because clinically people are asymptomatic and they have, their infection, their fevers have resolved, their symptoms have resolved, they're clinically improved. And essentially what you're just picking up is non-viable particles on that PCR testing. Now, unfortunately, in a healthcare system, we are sort of stuck doing these tests. So sometimes people may not be familiar with it and think that this is really the standard, that we have to keep repeating PCRs on people, when in fact CDC guidance does not say that. You're infection free once you're out of, in fact recently CDC even loosened their isolation guidance even more to about 10 days. So it's fever free 72 hours, 10 days from symptom onset, but you can use the whole 14-day quarantine isolation period as your guidance. And sometimes people that are more severely ill that are hospitalized can be infectious for up to 20 days. We say that. But the PCR test, generally, it's not recommended for the general public to repeat that test because we know that those tests can be positive for a long amount of time, but not necessarily mean that people are generally infectious. When it comes to antibody testing, there is no, at this point, it is not recommended to have your antibodies checked prior to vaccination, because again, as Alan mentioned before, even if you've had COVID before, it is recommended that you get vaccinated because the immunity from vaccination is so much more robust and long lasting than from just COVID infection itself. So it's not recommended that you check your antibodies, prior to vaccination. And because of the scale of the pandemic, we just want to get, everybody vaccinated as quickly as possible. If it's recent infection, that's a whole separate thing. There's guidance that you should be at least fever-free again for 72 hours and out of isolation before you vaccinate. There is some interim guidance that you can, if you choose, you can delay vaccination for up to 90 days if you've had recent COVID, because in theory, ideally, there's really no risk of reinfection in that short 90-day time frame. That being said, and then monoclonals comes into a separate category. If you've had treatment with monoclonals but because of COVID-19, then you do have to defer vaccination for 90 days.
That was one of our questions. And next question, excellent. So again, if you got one of the monoclonals, either the Regeneron product or the Eli Lilly product, you got to delay 90 days.
Have to defer 90 days just because there's no data right now. There is potential for possible, cross-reactivity, and we don't know, not that there would be a problem, but we don't know how good your immunity from the vaccine would be. So that's why if you think about the half-life of these monoclonals, you think, by 90 days, that should be out of your system. And then now you can get proper vaccination and know that you have good protection that lasts long, as opposed to having inadequate protection, having a false sense of security and getting infection then. So no, not recommended to get antibody testing before vaccination. And even after vaccination, right now, we don't have commercially available assays that are testing for, the spike protein versus nucleocapsid. So there's a lot of confusion with these tests. So it's not really recommended right now to have your antibodies checked after vaccination either. We know from the trials, as Alan mentioned before, and as you mentioned, Patrick, that it is essentially both of these are approximately 95% effective at preventing COVID-19, illness. So we know that the data is there, so we don't need to really check for antibodies. We know that it works. And once we have assays that are commercially available that are specific to just the vaccine, then possibly that guidance will come, but that'll be later. We don't have that right now. And so that is not the recommendation right now to check the antibodies.
That was excellent. Thank you, Uzma. So another question that just popped in, and this is a good one here. When you we're in phase technically 1B, right? So for those on the phone, we get guidance weekly. This is a sample from the Department of Health. It gives us guidance on who we could give vaccine to. Obviously, our healthcare employees are all phase 1A. 1B, 65 years of age and younger, and now we're moving into what would be technically phase 1C, which would include, and this was mentioned but not defined, and this was one of the questions that one of our viewers had. If I'm immunocompromised, has that been defined? Is it based on my background? I'm going to toss this one to Alan. Right now, I will tell you in conversation with the DOH, New York State Department of Health, they still have not yet defined what they would define as being immunocompromised. So, Alan, what would you advise someone who is immunocompromised? Obviously, the first phase is, get vaccinated. But what if not? I mean, what would you advise them?
Well, obviously, it's a broad term, immunocompromised. But I will refer people. There's a really nice review in the New England Journal. This latest by Paul Sachs, who's really he's a great communicator, and in there they'll talk about how do you define an immunocompromised individual. I think it's very broad, but if you have cancer, if you're a bone marrow transplant, if you're an organ transplant, you have an immune deficiency, a combined immune deficiency or an immunoglobulin deficiency, if you're HIV, if you're on steroid therapy or other immunosuppressant therapy, any iatrogenic immunotherapy, however you want to define that. So I would say, it's kind of a loose definition. Nobody's really, I don't think you're going to get a very tight definition when it comes to this. So the watchword is, if you have any concern about an underlying medical problem that puts you at risk, you should step up and get in the line and get a vaccine, because you really again, as I said up front, you're really playing the numbers. Do you want COVID? Your risk of getting COVID right now is higher than a risk of having a side effect from the vaccine. And if you're immunocompromised, as we've seen, all bets are off sometimes when you're sick with COVID. You could really have a very stormy course. And that's really the disconcerting part about this is trying to, it's a race against time, especially if you're immunosuppressed and you've made it this far without an exposure, without getting sick. That's amazing. Now at least let's get you in line to get a vaccine. So I mentioned some of those conditions, but I think it's broad and loose, and I don't know if the state or anybody's going to make it even more defined.
Yeah, I agree with you. I think further guidance would have to be coming on that. So we're coming up on almost the 5-minute mark left. So I want to save an opportunity for each of you to give a final pitch. So this is an opportunity. I think we've done a great job dispelling myths, laying the truth, laying the evidence out, and again, looking at risk-benefit ratio. And clearly the benefits of vaccination are just tremendous, and the safety profile and the efficacy, it all points in one very clear direction. But let's just go, maybe like a 1 minute or 90-second wrap up on, here's your opportunity to really make sure if there's anything we didn't touch on that you think you'd like to, and a final pitch to our amazing employees about how we're going to keep them safe. So Uzma, let me go to you first for a final thought.
Absolutely. I just want to say that, it's important for people to trust in science and really just challenge the source. As I mentioned before, there's so much misinformation that's being spread out there, and it's really up to us to really challenge the source, find the credible sources, and make sure that you are getting accurate information, because this is your life and livelihood. And it's not just about you, but it's your family, it's about your friends, it's about your community. So, we're all in this together, and we've been saying this from the start of the pandemic for this reason, that we have to really do what's right collectively for each and every one of us, no matter what age. As Alan mentioned before, what we're seeing in the younger population, most young people do get better and get over COVID, but I can tell you from personal experience, my very first patient that I saw was a 20-year-old who was so sick and gasping for air that he needed to be hospitalized, and he felt like he was drowning. And it's really scary. And, and these are things, we have teenagers that cannot, participate in their sports because, they have all of the long COVID symptoms, they have, cardiac issues, lung issues, and this is happening. If it can happen in the younger population, it's certainly happening in the older population. So the whole goal is that we want to heal people, and we don't have, a year into this, we do not have a cure for this virus. We have made a lot of progress. We have things that we can do to treat this early to help prevent the progression, but it doesn't work in every single person. And some people do get better and others unfortunately don't. And we just cannot afford to lose more lives every day. 4,000 lives a day, reaching this milestone of 400,000 people dying in our nation is just incomprehensible. And so, what we have right now is some real progress and really just amazing, amazing advances in science because of the entire global community coming together for the advancement of science with all the public funding that possibly could have been put into this, public-private partnerships, and just complete transparency. You can look online at any of these vaccine candidates and have all of the information from the trials. We're talking about close to 75,000 people that were in the trials for these 2 specific vaccine candidates that have been approved by the FDA. So there's a lot of data. There was also a lot of data on the demographics. So in both of these vaccine candidates, there were about 5% of the population was Asians, 10% were Black Americans, about 20%, 25% was the Latinx population. So, we have data, and, and this should be comforting, and all of us, in healthcare are stepping up to get vaccinated because, we're practicing what we're preaching. We believe in these vaccines, we believe in the safety and efficacy, and we're here to answer all your questions, and we really are in this together, and we have to do our part to really, get past this and really move on and get to some sense of normalcy.
Thank you, Dr. Syed, very, very much. Very well said.
I think you have to put it in historical context. I mean, certainly everybody has, fear about a new intervention, whether it's a medication, a vaccine, and time will tell. Sometimes there are things we don't see up front and that come later, but you have to be willing to accept the benefit is much, much greater than the risk. When you take a medication on a daily basis, you're making that same determination. The benefit outweighs the risk. So in the historical context of where we've come with this vaccine, even if you go back to the polio experience, a vaccine that took years and years to develop because of the type of technology that was only available at that time. Technology in all fronts, in all industry has advanced so much that we've been able to utilize that advanced technological speed to come up with a vaccine in such a short amount of time. And like they say, the data doesn't lie. It is available, it is transparent, and it shows it's effective. And when you're on the front line seeing COVID every single day and being beaten down by the number of patients that keep coming in and having to adjust and adapt to the treatment modalities, all you can think about is how do we get out of this? Come on, we just need some way out, and this vaccine is that way. And if we continue to believe in it and promote it, and hopefully there'll now be better logistical backing and distribution, and we'll see vaccine centers and these 1A, 1B, 1C, all that stuff hopefully will go away, and the general public will just have access to the vaccine in a rapid manner. And again, what I started out by saying is we're the leaders of healthcare. We need to set the example that we want a way out, that we want to satisfy what it takes to get COVID down to less than, I want to go back to the summer when it was below 1%. And you were able to, do a little more, and that's what we should look forward to. And the only way to get it down to less than 1% is to get our population vaccinated. Sooner the better. And we as leaders in the healthcare field should promote that same view of what these vaccines offer. So I urge everyone out there, to read and educate yourself and make your own decision. But the decision you should be making is to get a vaccine.